bringing together voices in child and youth healthcare. This is CAPHC Presents.
CAPHC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and the Children's Hospital Foundation of Manitoba. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAPHC's programs and activities. All right, hello everyone, and welcome to today's episode of CAPHC Presents. My name is Doug Maynard, and I'm the Associate Director at CAPHC, the Canadian Association of Paediatric Health Centres, and thanks again for joining us today. So today's webinar is part 2 of our 2-part series on social pediatrics as defined by the health and well-being of children and youth at risk, the disadvantaged, the dispossessed, and the discarded. Last week we heard part 1 where we brought Dr. Denis Daneman, Dr. Susanna Tallarico, Dr. Andrea Hunter, Dr. Tony Barazino, Leanne Chapman, and Dr. Isle Cohen to really introduce us to a number of interesting facets of this larger topic of social pediatrics. And this, of course, is building on, for those of you who remember, a series that we did a year ago. And all of this is done in partnership with our colleagues at the Paediatric Chairs of Canada, which at that time was chaired by Dr. Denis Daneman, currently chaired by Dr. James Kellner from the Alberta Children's Hospital. So it's my pleasure to welcome Dr. Daneman and Dr. Kellner back to help sort of co-facilitate, co-host this session, bringing another great panel to part 2 of this session. So it's my pleasure now to hand the virtual podium over to Dr. Jim Kellner to sort of kick this session off. Over to you, Dr. Kellner.
Okay, thanks, Doug, and good morning, everybody who's participating today. Really pleased to welcome all of you, and I expect that there are quite a few participants who were here last week as well, and so we hope that today's webinar will be a nice continuation of the presentations that came from last week. I am here in my role with both the Paediatric Chairs of Canada and CAPHC, and pleased to help introduce and oversee this webinar today. So as you know, we have 4 presentations over the course of the next 90 minutes, and our hope is to have the opportunity to listen and see the presentations and as well have some time for discussion. So we've asked each of the presenters to try to keep their presentation to somewhere around 15 minutes. As time permits, there'll be perhaps 1 or 2 questions or comments at the end of each presentation, but we do hope to have a significant chunk of time at the end for a more general discussion. So today there will be 4 presentations again. First we'll start with Dr. Lisa Robinson, who is at the Hospital for Sick Children in the University of Toronto, and that will be presenting on providing opportunities to enrich the lives of disadvantaged children and youth. After that, Dr. Lindy Sampson from CHEO in Ottawa will be presenting on shelter and food insecurity. And then we'll go back to Toronto. Dr. Sloan Friedman from St. Mike's and the University of Toronto will present on what the studies of school-based interventions tell us. And then finally we'll come out here to Calgary. Dr. Roxanne Goldade in community practice here in Calgary will present about the role of family services in foster care and child health. So these are 4 very diverse topics, and we will look forward to what everybody has to say. And at the end, Denis Daneman is going to provide some concluding remarks. I do, just before I turn it over to Dr. Robinson to start, want to borrow from my friend Denis Daneman's definition he presented last week of social pediatrics, and 2 key points in this. First, the definition that social pediatrics refers to the health and well-being of children, most specifically those living at the margins of society or who are disadvantaged, disabled, or dispossessed in some way. This description hinges on the recognition of the social determinants as critical mediators of child health. So I think that's a pretty kind of general understanding most people who are listening today would have. I do want to reiterate Denis's point that in a way it's an unfortunate term because it suggests that social pediatrics is somehow the exclusive domain of pediatric healthcare providers rather than society at large. And I think it's unfortunate both for those of us within pediatric care provision as well as outside of because clearly social pediatrics is a societal matter and a societal issue and not something owned solely by pediatrics. And I also just finally want to reiterate the purpose of this series as Denis laid out last week. There's really three things to say about it. The first is to move pediatrics and child health onto the agenda at the federal and provincial levels to maintain a strong light on the plight of the disadvantaged children and youth in our society and to extend the scope of the first webinar series from last year. So with that, I'm pleased to turn things over to Dr. Lisa Robinson, who will be making the first formal presentation today. Lisa, over to you.
Well, thank you very much. And before we start, I just wanted to thank you for giving me the opportunity to participate in this webinar and to tell you about some of the work that we've been doing here at Sick Kids. And again, before we start, I have to make a disclaimer, which is that I'm a technical idiot, as you can probably tell already. So if I have any trouble, I'll ask for some help. Just in the way, so I'm going to tell you essentially about a program here at Sick Kids that we started a number of years ago called Kids Science. And this is really about providing opportunities for teenagers and children. And can you see my screen okay?
Mm-hmm. Okay. Screen, but I can tell that you've clicked away from your PowerPoint slide. If you want to just click on your slide, just out in the middle of your, yeah, there you go, that's better.
Okay, perfect, great, thank you. As I said, I'm a technical idiot, so thanks for the help. And just in the way of background, as everybody here knows, there are many children in our community who face a number of challenges for different reasons. These could be physical reasons, social reasons, financial, geographic reasons. And because of all of these different challenges, they're sometimes not able to navigate their way through the post-secondary education system and then later on through the employment system. And as we all know, many of these kids become disillusioned in the school system and discouraged because they really can't see how it applies to them and and they don't see a clear path to their future. And there have been many studies that show that in particular it's science and technology that suffers. And so many of these kids will opt away from studying science, taking courses in the fields of science and technology. And the time to really try to reach them is before sort of late middle school and early high school, because by then they've really made their decisions and they've decided to drop these courses. So as a result of this, and looking at sort of the background literature, we decided to create a program which is called Kids Science. I'm going to tell you a lot more about that in the next few slides. So Kids Science was started in 2006, and really the purpose of this program is to help kids make informed academic and career choices in the fields of science and technology. So we really focus on students who are deemed to be at risk, and many of these students will have a lack of equitable access to science and technology awareness experiences. So the kids that we particularly focus on are adolescent patients who receive care at Sick Kids, because as we know, they spend a lot of time in and out of hospital, and for many reasons, they're often streamed away from anything academic because people think that it might be too hard, too rigorous for them. We also focus on kids from Toronto and from the Greater Toronto area who live in the so-called priority neighborhoods. So these are the neighborhoods in Toronto that we read about in the newspaper all the time, where the socioeconomic conditions are particularly the most challenging. And we also work with students, secondary school students, who come from remote areas of Ontario. So our partners for this program we have several partners. So the first is the Toronto District School Board, and we work with a number of different high schools and middle schools in the priority neighborhoods in Toronto. We also partner with the District School Board Ontario Northeast. So this is a huge area that really stretches from Temagami to Hearst. And so there are many First Nations communities that fall within this region. We also partner with a number of different community groups, and in particular with Visions of Science, which is an organization that was really started to try to help African, Canadian, and other underrepresented minority students to really achieve their goals in the fields of science, mathematics, and technology. We also partner with Horizons, which is a Toronto-based community program, which is really a learning partnership program that helps to provide academic tutoring as well as other enrichment, so in the fields of music, sports, etc., for students in Toronto inner-city schools. And they have a very innovative 4-week intensive summer school program that we work very closely with them, in which we work very closely with them. And so these students, we work with them, and the students come to spend some time here at Sick Kids with us, and I'll tell you more about that in a slide or so. We also work quite closely with the University of Toronto's Summer Mentorship Program, which has been running for many years now. And this is a program which is designed to give high school students of Indigenous and African ancestry a chance to explore not just medicine, but all of health sciences at the University of Toronto. And this is a summer program which is for high school students who have completed grade 10. So Kid Science involves a number of different activities, the first of which is a Speakers Bureau. And in the Speakers Bureau, volunteers travel from schools, or to schools, as well as to other venues, so community groups, community centers, to really share their research projects along with their enthusiasm and love of science. And we make sure that we send people who do very different kinds of science to speak to the kids. The second type of activity that we provide are science workshops, and we work not only within the classrooms here at Sick Kids, but also in classrooms again in the community and in various schools. And these are curriculum-based workshops. We work really closely with the teachers to try to understand what the kids are expected to learn, and to try to bring the work that we do to the kids in a meaningful way. And so what we try to do is have the researchers, and when I say the researchers, these are undergraduate students, these are graduate students, postdoctoral fellows, principal investigators, technicians. And what they try to do is to inspire the students by talking about not only their research, but also their educational and career paths. And it's always done in the context of hands-on activities and experiments. And everything is framed in a medical context so that it's not just science that's from a textbook, but that has some meaning to the kids. And one of the things that's really, I think, surprising to the kids is the people that come out to speak to them oftentimes look like them, and that's something that they don't experience in their every day. So the speakers bureaus and science workshops are run throughout the entire year, and they can be requested by anybody essentially, so by the schools, by the community groups, and really if we're asked to, we will go anywhere and speak to any group of kids. The second main activity for Kids Science is something that we call the Science Extravaganza. So we've been doing this since 2006, so this is an annual 2-day symposium which is really action-packed. And it's designed to try to inspire the kids participating to become the next generation of researchers, innovators, and science professionals. So the kids will have the opportunity to hear some cutting-edge lectures from phenomenal speakers. They also engage in creative group problem-solving activities. And they also have the opportunity to visit research labs or research programs and to participate in experiments going on in those labs and programs. So that's for one day. And on the other day, the kids, we do programming at the Ontario Science Centre. And many of the kids have never been to the Science Centre before. In fact, some of the kids have never even been to Toronto before. And we make sure that all the kids that are participating from out of town are housed in student dormitories at Ryerson University. And in the past, too, we've had some of our chronic adolescents stay in the dormitory supervised by one of our adolescent medicine physicians. And especially for some of the kids, for many of these kids, it seems very trite to us, but many of these kids have never visited a university before, and they don't know anybody that's gone to a university, and so this is a very impactful experience for them. And in addition to the 2-day science extravaganza, throughout the year we also conduct lab visits where we will have school groups or community groups come to visit the labs and the research facilities here at Sick Kids to learn about the biomedical research that's currently underway. So in addition to those, there are a number of other activities that we provide and participate in. So one of them is a medical school workshop. And as we all know, so many medical students have connections. And we really particularly reach out to the kids who don't have connections. And so again, we work in the high priority neighborhoods in Toronto, and we specifically target underrepresented minority students. And so we have run 3 of these workshops so far, always on a weekend, and the participants are able, and so in fact we had one a couple of months ago, and we had about 130 kids participating. And so when the kids attend the workshop, they're able to get some tips about the application process. There's always an administrator from the University of Toronto Medical School Admissions Committee. And the kids have the chance to hear from current medical students and to meet in small groups with sick kids physicians and other physicians. And in fact, Dr. Daneman participated in the last one. So again, the kids love this experience because they have the opportunity to interact with people that they would never have the chance to meet in their day-to-day lives. We also conduct a summer mentorship program where we take 10 high school students, and we've done this for the last 2 years, who are invited to spend a month basically at Sick Kids. And so they visit Sick Kids research labs and facilities, and they meet leading scientists and researchers. We also conduct programming for the patients in the hospital, and so we have Kid Science Adventures. So we work very closely with Child Life, and we participate regularly in the closed-circuit TV programming. And we take patients along on a live interactive science adventure, as I said, through our closed-circuit TV network. And so this includes hands-on kits that are given beforehand to the patients so they can follow along and participate in the rooms in the experiments that are going live on TV. And they can call in with questions and comments. And then just quickly, I wanted to just highlight a new program that we started last summer, which we call the STAR program. And so this is a summer program. It's a summer research internship, which is specifically for underrepresented minority students. And we felt very strongly that this needed to be a paid full-time job for these students because many of these kids cannot afford to volunteer for the summer. They actually have to make money during the summer. And as we'll talk about later on, so this was a pilot project, a pilot program, and Denis Daneman very graciously and kindly provided the funding. So for the first iteration of this program, we took 4 students, and I'll tell you more about the program. So overall, between 2006 and 2014, we've had over 14,000 students participate in the Kid Science activities. So what we're working on now is trying to figure out how best to evaluate the success of this because it's difficult to get the type of data that we would like to get from the Toronto District School Board. So the data that we're collecting, much of it is qualitative, and so at the end of every Kid Science activity, there's a questionnaire that's distributed. And the responses that we've had from the kids and from the teachers have been overwhelmingly positive. And I think in all the years that we've been running the program, we've never had anything that's been less than 8.1 out of 10, and usually it's 9 and 10 out of 10. And of the students who've responded, 64% of them have indicated a new interest or a renewed interest in pursuing science as a field of study. We also gather a lot of anecdotal. After a recent middle school speakers bureau event, 6 of the kids that participated developed science fair projects for their schools that were based on the Kid Science presentation that they heard. And 2 of the students went on to win prizes for these presentations. And at one of the other schools that we were working with, we were able to track enrollment in science classes. And what we found is that after participating in the science extravaganza, more students were choosing to enroll in science classes, and not just one science class, but these students were now taking 2 or 3 science classes. And that was different than what had been happening before. And so from this, so I'm just going to share some of the student feedback. As I said, we have lots of comments, and we find these very instructive, but I'll just share a few of them. So this is from a young student, a grade 7 student, who said, "I didn't know I could be a scientist, but I think now that I can be. I never got to see things like this. I hope I can be just like the people I talked to today. Thank you, and big hugs." Oh, I am having trouble here.
Just click, there you go. Yeah, now try it.
There we go. This from a grade 11 student. I feel that this workshop, this was the medical school workshop, by the way, has made my mind so much clearer on many topics that were important to me. Information like this isn't as readily and clearly available anywhere else, and I sincerely thank you for this amazing opportunity. And this from a grade 11 student. The best part was where we got to talk to the doctors. They are so cool. Can't say that I've ever been called cool before. But, and I just would like to thank them for taking this opportunity to come here and encourage us. And then lastly, from this grade 8 student, going to Sick Kids Hospital was one of the most greatest experiences of my life. I learned how to make homemade polymer, which is a scientific word for silly putty. I hope I have a chance to visit here again someday. So this is just a picture showing the first cohort of STAR students. So this is the summer program that we just started. So these were our 4 students who participated. This is Lauren Chan, who ran the program, Adrian Wong, who runs Kids Science in general, and then, of course, Dr. Daneman, who provided the funding for this program. And based on the success, and so at the end of the 6 weeks of this program, each of the kids was placed in a particular research program and research lab, along with many mentors in that lab. The kids were given specific projects, and they really became a part of that lab. And at the end of their time, they each did a PowerPoint presentation that was made to all of their mentors, their lab mentors, and Dr. Daneman was also in the audience. And I think it's fair to say that they blew all of us away. It was just incredible what they came up with. So here's just sort of a little smattering of some of the slides from the STAR student presentations. And so these are grade 10, 11, and and one grade 12 student. So, you know, they were using words like downstream signaling, you know, that sort of thing. So they really learned a lot, and it was very inspiring. So based on the success of this, Dr. Daneman helped to identify funding for this coming summer for 16 students. So we're really excited about this. And so here is just some of the, I'm just going to end with this. This is some of the student feedback from the STAR program from this past year. And you can see that, you know, this experience, so this is the percent of students who agreed or strongly agreed. And so again, we're trying to collect qualitative data. And so, you know, this caused all of the students to consider a future career in science and technology. And some of these students were not considering that as a possibility. And again, I won't go through all of this individually, but you can, I think you will appreciate that they felt that this was a unique experience, and they were very thankful for that opportunity. So with that, I'm going to end, and thank you very much for just letting me tell you about one small effort that we're trying to make here to address some of the gaps that exist. Thank you.
Thank you, Dr. Robinson. Before we move on to Dr. Sampson up at CHEO in Ottawa, we did have one question come in from Paul, and when you were going through the evaluation process that you did, he was asking if there was any kind of sharing of this data with the education sector.
Yeah, that's a great question, and so far we have not done that. So for this, the one, we haven't had a way to do this through TDSB so far. I'm going to be trying to work with our educational researchers here to see how we can do this in a more structured way. We've shared the data anecdotally with the schools and the community groups, but we haven't done it in a more formal way. But I think that's very important because that may help us sort of to leverage more resources for this program. That's a great question.
Can I ask Lisa a question?
Sure.
Lisa, Denis here. What happens if in the process of these kids coming to the hospital or having these experiences, you identify somebody who's very at risk, who has housing, food insecurity, you're really worried about them? Do we have a way of bringing that to the attention of anyone?
Well, that's a great question, Denis. So far, that hasn't happened, but you know, I think that's something that we really need to think about. And yeah, I mean, I think we need to put more thought into how we would do that. But for sure, I mean, one of the benefits of a program like this, and especially the kids that are here on an ongoing basis, is that they really become part of the research team and the lab in which they're placed. So, you know, not only are they doing the work, but they are gaining a number of mentors and friends that they do go to and they go back to with a number of different questions. So we'll have to figure out how to do that better. It hasn't come up so far, but I'm sure it will come up.
All right, thank you. All right, so now we're going to go over up to Ottawa to Dr. Lindy Sampson. Over to you, Dr. Sampson.
Great, thanks. Good morning, everyone. And once again, thank you for the opportunity to share this with you. And Lisa, thanks for your great initial presentation. Clearly doing lots of good work and really impacting the lives of these kids. And Dennis, for your great question, which is a segue into switching gears now to talk a little bit about how housing and food insecurity impact the health of children and youth that we all see in our day-to-day work, and more importantly, what we should do about it. So this is just a brief outline of what I'm hoping to go through and touch on today, and really it's been an ongoing learning curve for me about the significance of these issues in the presentation, the management, and most importantly, the short and long-term outcome of the children and youth that we see and care for. And it's really grounded or started in 20-plus years, I'm dating myself a little bit, of clinical experience, initially in general peds and then in infectious diseases. So let's talk about these issues, and I'm hoping by the end of the next few minutes it will seem more relevant and pressing as an issue that we should all engage in as individual clinicians and other professionals, as well as at an institutional level. So housing in Canada is actually a significant issue and is evolving. About 12.7% of households in Canada are felt to be living in housing need, using very well described definitions from the Canadian Mortgage and Housing Corporation that sort of keeps an eye on these things. We now, about 4 years ago, combined with 7 other pediatric healthcare institutions in the country and did a national pediatric housing survey of all children that came into our emergency departments over a 4 to 6 week period. And we found, quite surprisingly, that 52% of all the children and youth coming to our emergency departments, and it was pretty consistent across the country, lived in some sort of housing need. And briefly, that can be anything from inadequate housing, which is in need of major repairs, unsuitable housing, which fails to meet our national occupancy standing requirements that we talk about as I move forward as crowded housing, unaffordable housing, which by the CMHC definition is spending more than 30% of a household income on housing, but in fact we were very conservative and used over 50% of household income, and then unacceptable housing, which does not meet at least one of those standards. Not surprisingly, there were certain groups that were more likely to be living in housing need, and those were lone parents, people that were new to the country, either as immigrants or refugees, households where there was anyone living with a physical, developmental, or mental disability, and probably not as a surprise, people that identified as being from First Nations communities. So if that's the extent of the problem, 50% of the kids approaching our healthcare institutions, what's the health impact, or what do we know about it? And over the years, we have been able to determine that there are some associations, although you can appreciate that there's lots of overlap with poverty in general and with other markers of poverty. But when we look at physical quality of housing, or something that would be housing in terms of major need, there are significant issues, such as impact on asthma for children when there's poor air quality, headaches, difficulties concentrating. Poor physical conditions have been associated with increased mental health disorders, anxiety, depression, sleep disorders, and developmental delays. And anecdotally, we've heard lots about parents that come in with their infants who are failing to meet milestones, and they won't put their kids down on the floor, these infants, to sort of develop their strengths and motor skills, because the floor is just covered with cockroaches. And so these are very real implications of what are our core housing problems. Moving on to crowded housing, following the definitions, we know that this leads, in my bailiwick, into increased vulnerability around communicable diseases, increased incidence of respiratory illnesses, gastroenteritis, and even tuberculosis in communities where tuberculosis is an issue. It also, though, has significant negative impacts on social, developmental, and mental development, including poor school performance and differences in outcomes on standardized tests, etc. When we move on to housing stability, which is really about how often a child has to move houses, there have been shown to be long-term consequences in terms of overall development, sense of security, and relationships. And these primarily translate into inability or failure to be successful at school. We had a meeting with educators here locally, and some teachers reported that they had children that at the beginning of the year they had a whole class of grade 2 students, and by the end of the year not a single one of those students still remained in the class because they'd all had to move. That was from a high-risk neighborhood in Ottawa. In terms of affordability, it is nationally described as greater than 30% of the household income, but in our studies we looked at greater than 50%. And you can see that this would be automatically associated with things like inability to buy food, inability to buy medications, especially for those families that are not on social assistance that fall in between the gap, as well as being unable to pay for repairs in the home that lead to consequences for injuries. And finally, outside of the house itself is the place or the environment in which the house is associated. And there's been lots of good studies from across the country showing associations between the safety of the neighborhood and outcome for children from, again, a physical, developmental, and educational perspective. Other than the impact on housing itself, there's the impact on our system, and I think this is where we who work in institutions need to really step up and promote the fact that this is part of our business as institutions, and we need to be mindful of it. So poor housing has a significant direct and indirect impact on the system. We know that people that are poorly housed have increased hospital admissions. We showed in our survey locally here and in some of the institutions across the country that this also correlated with lack of access to primary health care providers and decreased access to subspecialists, but which has been shown from other data, not necessarily within Canada. But also, although more difficult to determine, the UK has done some work on looking at the direct healthcare costs of housing need, and they estimate it to be an annual cost of £600 million, which to me is just astronomical and doesn't take into account the indirect costs as well that would cost the system. So moving along from housing security, I wanted to talk a little bit more about food insecurity. And as I noted before, it's really linked to housing and poverty, and there's often trade-offs between the two. When you speak to families, they'll often talk about making decisions about improving their housing need versus being able to feed the family. And there's even trade-offs within families, whereas you often hear parents skipping meals to ensure that their children don't have to do so. But it's surprising in this Housing Food Insecurity in Canada paper that was put out in 2012, there are a significant number of children in the country that are also having to skip meals over a day or sometimes for a day at a time. In this paper, they talked about 13% of Canadian households in 2012 being in housing need, being food insecure, and that amounted to about 1.15 million children. Interestingly, the majority were working families, although if you look at the total numbers, 70% of those on social assistance were living with food insecurity. And food insecurity is complex, as are all of these issues, but there's things like accessibility to food and to grocery stores, the geography of the environment of where people live and whether food can be grown anymore or how it can be grown, obviously the cost, and then changes in the way we procure food and sell it in the country. This is just a snapshot from that same paper that shows the variability of rates from a low of 11.5% in Alberta to a high of 45.2% food insecurity in Nunavut. So what do we know about the impacts of food insecurity and health? You know, there can be a long laundry list of things that have been shown to be associated, but I've highlighted some here. That ever being hungry in the last national survey that was done, or multiple episodes of hunger, were associated in children and in adults with just a poor feeling overall of how healthy they were or they weren't. And that was 20.7% in those who were food insecure versus 9.3% if they were food secure. Hunger or severe food insecurity in Canada has been linked to nutritional inadequacy, both malnutrition and specific micronutrient deficiencies, as well as obesity. Chronic diseases, and in the pediatric world, really asthma is what is highlighted, but in the adult population, a very significant correlation with diabetes, high blood pressure, and other ones. And I think dental decay, although I haven't seen specific pediatric data, would also be very relevant to working with children and youth. The other thing that food insecurity has been shown to be is school success, cognitive development, and psychosocial development. And if we look at the pre-pediatric age, we all know that the health of children starts with their antenatal health, and poor birth outcomes have definitely been shown amongst women who have inadequate nutrition during pregnancy. So if that's what the problem is, we need to ask ourselves, if it's such a problem, what can we do about it? What can we do about it as individual clinicians and other professionals, but as well as institutions that are caring for children? And I use institutions very broadly here as healthcare institutions, but also as schools and school boards and other social service institutions that have the health and well-being or the overall well-being of children and youth at their heart. So we asked ourselves this question after we did our initial housing survey, which was just done at CHIO in about 2005, and we found that we really didn't know what the next steps were. So we brought together a group of people from different sectors in our community, from the health sector, from the education sector, from our youth sector, social services. We brought together the city, we brought public health officials, and we had a forum to ask, what can we do about it? And we looked at things that could be done at an individual patient and family level, and then at a community and policy level. And the number one thing that we heard, especially from healthcare professionals, was we don't really know what to do. Please let's develop some sort of toolkit that can be used. And in fact, we went ahead and did that with some support from various groups, and it ended up being a really great endeavor that helped build a lot of great relationships to move things forward, as well as to provide a toolkit that health professionals could use, but as well as other professionals in the community. And I think now it's actually used more by social services in the community than even by the health professionals here. So the first thing we decided, well, we need to screen for housing, and I've thrown in food insecurity because we're talking about that as well. And what we did is we developed a screening tool, and I'll forward the link to Doug for the PowerPoint, and you can link onto it, but some screening questions that really take 30 seconds, and they're on a scale of 1 to 10, how would you rate where you are living now, and what would you like to make better about where you are living? And then based on the outcome of those, there's a form, and there's even an impression and plan that you can write at the end that breaks it down into the acronym HOME, which is harm, occupancy, moves, and is there enough money, to sort of take you through another series of questions that can help dig down the issue a little bit further and know where you need to refer it. So once you screen and identify an issue, what are you going to do about it? Well, we found that a really important thing was informing patients about how their housing and food situations were impacting their health. We developed fact sheets and resources that can be given out, and it really helps form a partnership in creating solutions together to develop strategies at a personal family level to mitigate these impacts. We also know the importance to refer to resources that already exist within the community, so you need to know what they are and work with community partners to develop a mechanism by which referral can happen easily. And we did develop a local referral tool that's been adopted in different communities in our region and in some other provinces that has proven to be very helpful. So that's what we can do at the individual level, but what can be done at a community and population level? And part of it is just knowing what the extent and impact of the issue is, and we're getting better at doing that. But we also have a role to ensure that the people making decisions and policy program development are aware of the health impacts of these issues that are sometimes seen more as social issues than health issues. And what we learned is it's very important to bring the health lens to that conversation, and it's very important to pool with other sectors such as health, education, social services, legal, etc., so that our expertise grows and our scope of expertise is broadened, so that when we're talking to policymakers together, we're really giving the full breadth of the issue. And it's always important to present the information in ways that are relevant and understood. With regards to housing, Canada is the only G8 country without a national housing strategy. Yet in the Universal Declaration of Human Rights that we signed after the Second World War, as well as the UN Convention on the Rights of the Child, we've committed to providing housing in these contexts. So one other thing that we did moving forward with the national partnership after the survey was develop this Canadian Child and Youth Health and Housing Action Statement that is on the web, that has been supported by the institutions below, including CAPHC, as well as the Paediatric Chairs of Canada. So thank you, Denis and Jim, for that. And we're hopeful that more and more people will sign on to it. And it really commits us to acknowledging that these are issues that cross into the health sector, that we should recognize them within the clients that we serve, encourage research in these areas, and support policy-level decisions that will improve it. So what can we do just in the last 2 minutes? Individual clinicians, we need to understand how this impacts the patients that we see, know the problems in our community, implement routine screening questions, and I'd be interested to know who does and doesn't implement them already, know about and refer to appropriate resources, and advocate within the community and policy levels. What can we do as institutions? I think as institutions we really need to step up and acknowledge that this impacts all patients that we care for, that it also impacts our bottom line, but more importantly it impacts how people can access and follow through on our services and care. And we need to work together to create and implement innovative ways to mitigate these issues. So things like bringing good food box programs into the walls of our institutions. We heard last week about pro bono law partnerships that started at SickKids but have developed in other healthcare institutions, including our own, that have had really tremendous impact. And then we need to learn how to triage our now scarce resources in hospitals to ensure that the most vulnerable individuals are being seen. And we need to support the development of more research and evidence creation. So I'm going to stop there, and I'm interested to hear any thoughts or comments. Thank you.
All right, thank you, Lindy. And I just wanted to point out that at that housingandhealth.ca website, their endorsement column, both CAPHC and the Paediatric Chairs of Canada have both listed themselves as supporters of that work many years ago, so it's great to see.
I think I mentioned that, but yes, thanks for bringing it up again.
So we'll just take one. Sorry, go ahead, Denis.
Can I ask a question? Do you have one?
I do have just one quick question here, yeah.
Go ahead.
Leo's asking, he says, given the long wait for housing and the difficulty of obtaining services, is screening useful? He said, is there a follow-up on the yield of these referral in terms of positive outcomes for families?
Great question, and a very frustrating situation that we all find ourselves in, where wait lists for subsidized housing can be somewhere up to 10 years for some families. However, there's other benefits to the screening other than subsidized housing. So one is just simply being able to inform individuals and acknowledge that it's impacting the healthcare and find other ways to mitigate. So, for example, if there's ways to provide other access to resources that will free up some money for housing, to improve housing, etc. The other issue is that families can often make some choices, although very difficult, and once they're aware of how it's impacting health, can be assisted to sort of figure out what the best way forward is for them. But also there's more, sometimes people don't need subsidized housing, but they need to know their rights as renters in terms of accessing landlords and getting rid of the cockroaches or those kind of things. So although it's very frustrating, I do think it's valid, and there are other ways to mitigate the impact.
Dr. Daneman, if you have a question, go ahead.
So my question comes down to sort of global things that we can do. It seems to me that the role of school meals, either school breakfasts or school lunches, would go a long way to resolving some of the issues to do with food insecurity, and perhaps a raised minimum wage would do something for housing insecurity. You want to comment on that?
Yeah, Denis, I think those are great suggestions, and I unfortunately didn't have time to go into them. But our role as healthcare institutions and healthcare practitioners and educators is to advocate for those programs within schools. Breakfast programs have been shown to be very, very successful in terms of getting kids off to a good start in the day. Some of them can be publicly funded, but sometimes there's also been public-private partnerships to find the funding to do those. Bringing in the health lens to the people making those decisions to show this isn't just about the kids not being hungry, but impacting their health can sometimes really help with that. And the whole concept of guaranteed income in this country is one that's very worthy of debate. And for sure, many people in Canada living on social assistance do not get enough resources to provide for both food and housing in any given month. And we could certainly have a lot to say. And from across the political spectrum in this country, from very conservative senators to the very left wing, that there are folks that are really pushing for that now, and we could loan our health lens to that as well.
Thank you.
And now we'll move back down to Toronto, over to Dr. Sloan Freeman at St. Michael's University, or St. Michael's Hospital and the University of Toronto. Over to you, Dr. Freeman.
Hi, thanks so much, and thank you so much, Dr. Daneman, for inviting me to participate with this webinar. So I'm just going to speak about school-based healthcare and the lessons learned both from the American experience and our fairly new Canadian experience here in inner city Toronto.
Just clicked away from your slide. If you just click on the middle of your slide, of your PowerPoint slide. Yeah, there you go.
Okay. This slide, for me, really highlights some of the sort of major concerns that we have seen with our program and both with the American experience in terms of mental health disorders. And, a Toronto-centric statistic here is that 30% of senior kindergarten children are not ready to learn when they enter school, and that's based on an early development instrument that measures development in 5 domains. And that statistic is fairly interesting because if you break it down into different sort of income brackets, we see that children in the lowest income bracket are certainly less ready to learn than those in a higher income bracket, and in relative terms, the percent of children not ready to learn in the lowest income bracket is actually 2 times that the percent in the highest income range. And we know that these families who are in the lower income brackets face many barriers. Those are the families, of course, living on the margins of society. Those are the disadvantaged families. And for so many reasons, they face barriers to accessing health care, which is really the impetus for the school-based health clinic or health care model. It's meant to alleviate many of these barriers. That's located in a school in the child's and family's community, which is fairly easy to access in terms of location and geography, but it's also comfortable. It's in their community. They're familiar with the school, the staff, and we're fortunate to have multilingual clinic coordinators that can help us navigate the system in different languages because of our multicultural community, which I'll touch on in a few more slides. First, I'd like to just go back, before we talk about the Toronto experience with school-based healthcare, and look at the American experience. This is fairly new for Canada, but actually in the U.S. there are almost 2,000 school-based health centers. And what's interesting is that 75% at least now deliver some sort of mental health care. And that's because their experience, like ours, shows us that the needs of these families and children in particular are really sort of developmental and mental health. And that's why their school-based health centers and ours as well have really focused in many ways on delivering mental health care or developmental health care. I'm just going to touch on a few studies from the American literature which highlight 3 main messages, which is that these school-based health centers do improve access to health care. The second message is that they improve quality of life, and the third is that, again, they do focus on mental health care. This study from 2008 is a very, very large study looking at school-based health centers in the U.S., which showed that 2/3 of students in a school with a school-based health center, in fact, enrolled in their school health center. They made approximately 1 visit per year. 2/3 of the clinic users had public insurance. So remember, this is a U.S. model, so that's as opposed to private insurance, and that's sort of a proxy marker for more disadvantaged children. The top chronic illnesses that were seen in the school clinic were ADHD, number 1, and then asthma. So again, highlighting the developmental mental health concerns, with the number 1 chronic illness being attention deficit hyperactivity disorder. Another study a large study showed that children who use school-based health centers in general had less difficulty receiving treatment for their illnesses and injuries, had less difficulty receiving immunizations and physical examinations, and this was also related to less ER use in the community. So again, improving access to care. So the second message, which is quality of life, is shown in this, again, large study by Terry Wade from the U.S., actually is now in Canada, showed that in a very large study over 3 years, there was a significant improvement in health-related quality of life for students, especially for psychosocial health, again, touching on this mental health piece. And in fact, when they looked at who benefited the most, it was those who had impeded access to care. So again, those that were disadvantaged and facing more psychosocial barriers. When we look at mental health needs, we've seen in many studies, and in this one in particular, that use of a school-based health center, an SPHC, is related to decreased absenteeism. And in this study, fewer discipline procedures for the students who, in fact, use the school health center for a variety of reasons. This study from 2010 was an adolescent study. It's many of the studies in the U.S. are, when it comes to mental health, they focus on the adolescent population. This study showed that adolescents who used school-based health centers increased their use for drug or alcohol use or other mental health problems. And then overall, I want to highlight that when we look at the literature from the U.S., their message is that it does improve access. So if you build it, they will come, and especially for those students with ADHD or mental health problems, and also those with asthma as well. It does improve quality of life for these students, and particularly for those who need it the most, those facing the most barriers to accessing health care. So from the U.S. model, now I'm going to change gears and talk a bit about our Toronto model, which is now in its 4th year, and it's called the Model Schools Pediatric Health Initiative. And it's a school-based, now mental health and developmental care program reaching underserved and economically disadvantaged children who face barriers to accessing health care. It's a partnership, as you can see with all the logos below, with the Toronto District School Board. And originally, when we started, we didn't know what we were going to see, but quickly after the first year, we realized that the needs were, in fact, developmental and mental health, and that's why it evolved into a developmental health care delivery program at this point. This is our school. It's Spruce Court Public School in Regent Park in Toronto. It's our home-based school. Our health clinic is in this school, and we serve 37 inner-city schools in and around Spruce Court. The students will come from these other feeder schools and access our clinic, and one of the sort of innovative pieces of this is that we, the physicians that staff the clinic, will actually go out to these feeder schools to sit in on school support teams where high needs and high risk students are discussed, and we help determine which students need a pediatric developmental assessment and then arrange for this to be done at the home clinic here at Spruce Court. So this has been slightly renovated since this picture, but this is how it started in a converted classroom. You can see we brought in some medical equipment. We left the map up on the wall, and this classroom became a health clinic. This is one of the first children we saw about 3 years ago now. She was 3 years old in this picture, a refugee from Africa, and she was actually referred to the clinic because she had no words. She did not speak at all. And I've just highlighted in the bottom left corner the pencil sharpener, again, just to underscore this sort of non-traditional healthcare delivery environment, the pencil sharpener with the blood pressure cuff. And this is a picture of Nelson Mandela Park Public School. This is the school that we are going to move to because it's a much larger school, and it is a very special school in Toronto. It is the first publicly funded elementary school in the city, and of course named after Nelson Mandela. And this school is really sorry, there was I'm not sure if that was a question, but this school is really the heart of the Regent Park community and part of the redevelopment of Regent Park in Toronto. Moving on. So from our Canadian Toronto experience, we've collected data and we've published a study. And looking at some of the demographics of the families we've served, we see that 2/3 of clinic users live in households with a total family annual income of less than $30,000 per year. And these families, their first language is not English. So right off the bat, we can see these families are facing many barriers in general, and certainly barriers to accessing and navigating the healthcare system. I've just shown this slide because it highlights the diverse cultural communities that we serve. 38% of clinic users are South Asian, and you can see the breakdown there. Again, just to underscore the challenges that we meet when we serve this sort of very diverse population with languages and cultural barriers and all the reasons that we've sort of established the clinic in the first place to help alleviate. This slide was taken from the sort of first 1 to 2 years of the clinic, and at that time, you can see in the x-axis there all the different new diagnoses that were made. So these are diagnoses that were made in children at the school clinic, and they were new in that these children did not have these diagnoses prior to coming to the clinic. And what's interesting is in those first 2 years, over 50% of new diagnoses were in the developmental category, and now they are much higher. It's more like 80%. So just to keep it short and sweet, the overall message here is that from our experience and also from understanding the American experience, the unmet needs of our children on the margins of society and those that are disadvantaged are developmental and mental health in nature. And we feel that schools are really the perfect place to identify students with developmental and mental health disorders, particularly because they are in a classroom setting and the teachers work with us and are really our best partners in identifying the children that need to come to the clinic. And then again, the best place to deliver the developmental and mental health care because we are able to alleviate so many of the barriers to accessing healthcare by being right in their home school. And I will see if there are any questions.
All right, thank you, Dr. Freeman. So we don't have any questions from the audience at this point. Dr. Daneman, did you have a question?
I always have a question.
Yes, I've learned that.
These programs are terrific, and they're sort of part of the attempt to recreate the social security net. But recreating that requires that it have sort of links to the home and to the secondary, tertiary, quaternary healthcare system as well. How do you envision that developing over time?
Right, and that has been a challenge. So again, in terms of links to primary healthcare providers and these students' sort of own family doctors and primary care pediatricians that they have. I mean, of course, we're not replacing that, and this is not a primary care model, so we're not replacing that in any way, but we sort of think of this as an adjunct to that, and we try to keep all the primary care providers, in the circle of care, keep them, we copy them on all of the notes so that they are in the loop, and we sort of try to work with them, but it is a challenge. In terms of, other providers, we work with the sort of community mental health agencies just as we would if we were in our home at St. Mike's and try to keep sort of the communication open that way. We've gone out to some of these agencies and spoken to them about our program so that they are in the loop. But again, that has been a challenge, sort of keeping the circle of care closed and the communication with all the different providers going.
It's Jim Kellner here. I'd like to just ask a quick question as well, if I could, please, Sloan.
Sure.
So thanks very much for that. Really great. Just, obviously one aspect of this approach is to provide improved access to care closer to home, I suppose.
Right.
But a couple of things come up. Children's schools are not always close to their homes, depending on the city and the region and where schools are built and where the children live. And then in the picture you showed a child there with their mum. And how have you addressed the issue of sort of access to this care in terms of the hours that you have available for the program? Do you look at after school hours or even through evenings and weekends for availability? Or has there been consideration of that in terms of improving access? And also then you spoke about the work to keep the primary care physicians and regular caregivers in the loop, but how would you say you've done in terms of continuity of care, and especially given that school-based programs are likely going to be guided a little bit by the school year, and so a built-in sort of gap, or have you looked at providing care throughout the summer as well?
Okay, yeah, so many great questions there. In terms of just the last one, continuity of care. So yeah, again, we are limited in many ways by what we can provide within the schools themselves, because our partner is the school board and we have to sort of work with them. For a variety of reasons, they have asked us sort of to work within the school hours. So we run from, within the school academic year, but then when there are students that need to be seen over the summer, we will bring them to St. Mike's to see them over the summer. It's not a perfect model, but we are hoping to keep the school clinic open over the summer, over the next year or so. We're just working with the school board on that. In terms of the hours, we run during school hours, and a little bit before school starts, which is a very popular time for parents to bring in their children so that they don't have to miss school. The school board, again, does not necessarily want us running beyond school hours, and certainly not on weekends for a variety of logistical reasons. So that's been a limitation in that way. In terms of I think the first question was sort of about geography. It's not always in this child's sort of neighborhood or community. That's certainly true, and we are one school-based center serving 37 right now, inner city schools, so they're not all close. We have found, though, that we sort of overcome the geography limitation because we're within the school board. There's something just very let's say familiar and comfortable about being there that families still come. So the no-show rate is quite low compared to our St. Mike's no-show rate, and even though we're not necessarily physically close to all families and all neighborhoods, they still come. There's just something familiar about being in the school board, and they still come. We don't have a busing service or a way to transport them, unfortunately, yet, although we'd love to look into that for the future.
All right, thank you. We will take one quick question from the audience before we move over to Dr. Goldade. The question came in from Lee, and she was just asking, do you have access to a full-time psychologist?
I wish. We have, what we've done is sort of leverage and work with the school board's resources and with their psychologists. It's tight, and the psychologist is very stretched already. So again, what we do is sort of advocate as best as we can for the students that we believe need psychoeducational assessments. But again, we don't have a dedicated full-time psychologist at this time, although we would, of course, love one.
Thank you. All right, so let's head out west to Calgary with Dr. Roxanne Goldade.
Thank you very much. Can you hear me okay?
Yeah, we can hear you great.
Marvelous.
I want to say good morning to those out west and, of course, good afternoon to those out east. And thank you very much for giving me this opportunity to talk a little bit about health care for children in foster care. I have no disclosures except to say that I am showing a few pictures of my children, and I did ask them for permission. My objectives, I've got 3. The first is to describe what are the best practices when it comes to providing optimal health care for children in foster care, to have a little bit of a conversation, I guess, about why we fall short for these kids in care, and maybe some thoughts about improving things. But first, I wanted to start with a little story. It'll be brief. I did see this young lady, her pseudonym is Lizzie, last fall. She's a 10-year, 9-month-old girl, and she attended at my office with her brand new foster parent of 8 weeks and her caseworker of 12 weeks. Her story was that she had lived with her biological mother in Ontario until 2012, when she was, I guess, 8 years old. Then she moved to Calgary to live with her biological father. Since being in Calgary, she had mostly been in foster care because of significant negative behaviors. She tended to swear, there was lots of property destruction, and most unfortunately, she'd also been sexually assaulted while she was living in foster care. And then in the fall of 2013, she then spent 3 months in our Alberta Children's Hospital mental health inpatient unit and was diagnosed with post-traumatic stress disorder, attention deficit disorder. Apparently, Strattera had been started while she was in the hospital, and I was told she'd been on Concerta at some point in the past. And she also was given the diagnosis of oppositional defiant disorder. When she was discharged from the Children's, she went back to her biological father, but an example was she was throwing rocks at the window, stating that her father was abandoning her, and he couldn't tolerate it and put her back into foster care in December of 2013. Now, I saw her in the fall of 2014, and when she arrived in my office, there were no birth records. I did not get any discharge summary from the mental health admission the year before. She was on no medication since she'd been discharged. There was a strong family history of mental health issues. On exam, I described her as chatty and insightful and worldly wise. And my plan was to start by gathering data, as I said, from the Children's Hospital, from the caseworker, from wherever I could get it. Something as simple as she was in grade 5 and I didn't even know if she'd been vaccinated appropriately. I was told her counseling was on hold for some reason. I wanted to get some learning assessments, maybe some ADHD rating scales, try to touch base with the school, find out what her IPP or individual program plan was about, and give some thought to follow-up. So all that was apparently within 1 hour, and I had as I always call it, lots of homework to do on Miss Lizzie. So then I reflect upon what are some of the barriers for children in foster care and why such a presentation, such a consult doesn't go as smoothly as maybe another would. And here are some comments. And for most of you, this is probably not rocket science or new to you. Children and teens in foster care have a very high prevalence of chronic medical, dental, mental health, developmental, and educational issues. They require and receive more frequent and detailed health monitoring than other children and teens, and that despite our best of intentions, there are inherent barriers resulting in fragmented and often crisis-oriented care. As well, when these teens and these children are removed from their families, they're also removed from their usual system of health care, if they even had one in the first place. And I just sidestep for a second and speak about the new signs of safety approach. And I don't know what's happening in other provinces. I suspect it's been across the nation, where kids, the challenge or the hope is that they're not actually removed from their biological family's care, but instead placed with kin. That's supposed to be the optimal. And that happened about a year ago here in Alberta, and it has shifted how we provide care, and interestingly enough, not necessarily for the best. And we have to sit down and reflect on why that is, but that's what we're working with at the moment. Some more barriers include the lack of a medical home. However, I offer an alternative that it could be community-based, and in fact, I'll share with you a project we have in Calgary called PCC, Paediatrics for Kids in Care, where it is indeed community-based, and we don't have a specific site that the kids are sent to. Another barrier is inadequate and delayed assessments of their needs when they come into the system. We have significant difficulty accessing their medical records and their information. I regularly use the story of who is the keeper of their story. Normally it's a mother or a father, but these kids have no keepers. And then we have a lack of access to other healthcare services such as mental health screening, respite care, developmental and educational screening and care, dental, medical subspecialty care. We just can't get services. We poorly coordinate, and communicate amongst our disciplines and our systems of care amongst professionals and families. And personally, I have high hopes for electronic medical records or interprovincial records so that we can share information. We also struggle to diffuse authority and responsibility amongst parents, whether foster parents or birth parents, kinship caregivers, child welfare workers, and another huge challenge is confidentiality and consent. We also have a lack of knowledge on how to provide health care for these kids, both for the social services workers, the legal system, the medical folk, the paraprofessionals, and clearly a lot of these kids have multiple systems in their lives. There's a myriad of languages and cultures involved, a lack of knowledge about standards of practice or mandates or roles of those systems, and then we don't know how to align ourselves, align the goals and incentives of all these various people. I mentioned it already, but indeed, lack of money. We need, well, money. These kids are complicated. They aren't just 1 hour of work. They're several hours worth of work. We don't fund this well. We don't have enough bodies to take care of these kids, and we don't have enough treatment resources to take care of them, especially for their mental health needs. So I'm just going to quickly reflect upon two statements. One comes from the Canadian Paediatric Society. It's titled Special Considerations for the Health Supervision of Children and Youth in Foster Care. It was published in February of 2014. Worth peeking at. It's nice and short. And the second is the American Academy of Pediatrics Statements, Healthy Foster Care American website, filled with lots and lots and lots of information on what we should do better and what we should do well. So I'll just reflect quickly on our Calgary experience. I'm the physician lead for the PCIC program, Pediatrics for Kids in Care. It's a collaboration that started back in 2006 between our Department of Peds and Social Services, basically acknowledging that, yeah, there's a whole lot of barriers, and yeah, we don't probably do this very well. So we built a new triage system and a new funding structure, and we started seeing patients in 2008. It's very community-based. There's about 18 community pediatricians that provide consultations, offering about 30 slots, approximately 1 hour each per month. And we've been able to meet our mandate. We were able to see every single child that came into care that was apprehended. Our goal was to provide simple, accessible, comprehensive, and universal access to medical care for these kids. We tried to be very standardized in our diagnostic process and our report writing. I wanted to make it very easy so that our pediatricians wanted to join us and make it easy to keep and share the story. Our goal was to maintain placement for these kids, foster permanency planning, and minimize fragmentation of care and foster their supports and therapies. We wanted to build relationships between biological parents and foster parents, the medical community, the social workers, teachers, dental folks, psychology, wanted to improve the outcomes of these kids and minimize their involvement in the justice system. So reflecting on the Canadian Paediatric Society statement and the American Academy of Peds, this is what they told us we should do. This is standard of care. Children and teens in foster care should be seen early and often. At that initial assessment, they should be screened for health conditions that require prompt medical attention, such as acute illness, infection, pregnancy, chronic conditions that required medication. And in our system here in Calgary, our children are actually seen within 0 to 8 weeks post-apprehension by usually a family physician, because we've been able to liaise with our primary care network. So we have family docs that can see those kids in those early times. This is not the comprehensive assessment. This is just early urgent issues. And of course, it's emergent. They go to the emergency room. And then the child and youth should have a comprehensive medical visit, including, it gives everybody time to gather the story. They have 8 weeks. Our caseworkers have 8 weeks to go and dig up information, such as birth records, such as their placement history. At that comprehensive medical, they get a complete full physical exam, and yes, we screen for significant developmental or mental health disorders. we speak to, they need vision checks, hearing checks, and all of our kids now get seen by a dental worker and move through our oral health program. And during that initial assessments, of course, we evaluate whether they need screens, and sometimes we've got places to get assessments actually done. Guidelines from both the Americans and the Canadian state routine ordering of tests, and we're primarily talking about blood work and urine tests, are not recommended. We work hard to get signed consents from everybody, bio family, foster family, kinship caregivers, and then we try to coordinate care. My little comment at the bottom, yay for email, as long as it's secure email, has helped foster this, the ability to quickly rifle off an email to say, you know, was this child seen by audiology and what was the result? It makes it really easy to gather data. The other little challenge has been insurance, and clearly we have healthcare insurance, but things like dental care, and I think that's one of the catches when kids are in kinship care, it makes it difficult to get consent for dental work or vaccinations, and we still have to figure out how to jump through some of those hoops. But insurance is another problem, because if I want, say, a psychometric test done, it isn't as simple to say, hey, school, give it to us, although now at least maybe I can get the kids into the queue to have it done. And at the bottom of my slide here, it speaks about UCAPES, and we were able to build a relationship with our University of Calgary psychology program, and so now many of our kids can have psychoeducational or psychometric testing done through the University of Calgary, so that's been super duper helpful. Speaking to the idea of a medical home, we originally tried to model our program out of one site, so a physician would drive to, usually it was the social services office, but in our particular case, I don't know if it's just Calgary's so big or what, but we've made it more virtual, so our pediatricians see the children in their own offices, so nobody is driving, although we try to make it geographically appropriate so that if a child lives in a certain sector, they see a pediatrician in that particular sector. We communicate very much by email, through our electronic medical records as a way to share information. And our connection to our primary care networks has become quite crucial. So not only do the family docs see the kids early on, we also get to discharge our kids out to the family doc knowing that they can liaise back with the pediatrician if they need to. The guidelines also say that we should be partnering with our child welfare professionals to establish good medical records that follow those children. So again, I think EMRs are helpful here. And in Alberta, we have NetCare, which has its pluses and minuses, but trying to utilize that system should be helpful. And I think it also would be super useful if we had a database. And one of my hopes is to establish a provincial database for our kids and how well we're doing with them, as well as a national database. And I think there's a huge role here for provincial bodies, as well as the Canadian Paediatric Society, to make this type of information available. We need to foster relationships amongst healthcare, dental healthcare folks, child welfare, the legal system, judicial systems, and at least here in southern Alberta, we try to have a lot of meetings where we get all those folks actually in the same room and share stories and ways to improve the system. We've probably done that at least twice a year. We also one of the guidelines was to provide health information and education to the children and the teen in care, as well as kin. And in Alberta, we've been lucky. We've got some money to hire several nurse clinicians, and their main role is to provide information to our families with respect to medications, especially psychotropic medications. We need clearly to coordinate efforts regarding permanency planning, and the whole idea that planning needs to be personalized for each one of these children and help provide them with tools for their lifelong goals. And the last, one of the biggest challenges is providing follow-up. And in our own program, we've built it in that we provide that big comprehensive initial assessment, but we've got several follow-up visits that have been built in. But the idea is really to help them establish a relationship with a family physician, and then we become the consultants. At that follow-up visit, though, we review the medical history. We hope that our recommendations were honored and arrange for additional follow-up with ourselves or perhaps with a family physician. And I can't say we're superstars at this, but we try really hard. Physicians need to be very sensitive about each family and each child's unique cultural, emotional, and spiritual needs. And very particularly with respect to Aboriginals. Very much a challenge. We've been trying really hard to liaise with our First Nations folks, but I do think this has been challenging, and I'm not so sure we're doing it very well yet. And that was my musings on some of the barriers and at least something that we've been trying here in Calgary called PCIC. And I left my email address there, so if anybody does have specific questions or want to share, I'm happy to do that. And I should also quickly point out that I'm actually on the board of directors for the Canadian Paediatric Society, so this is one of my passions, and I'm really hoping to make this much more national, a much more national conversation. Thank you.
All right, thank you. Dr. Daneman, do you have a question?
Of course. Roxanne, when you look at it from the focus on the foster family, at the two extremes, foster families are often looked at as guardian angels, and at the other end as part of the problem. How does one assure that there's somewhere more in between, a more rational view, and how does one weed out those that might not be the most appropriate people to foster a child?
Oh, this is such a challenge, because one of the catches is we don't necessarily have enough foster parents. But even those foster parents need a lot more education, and we've looked at our program at PCIC. I mean, I've done a numerous number of talks specifically to foster parents because they've invited us, and they want to know, what is best practices, how do I get back to a doctor, and our nurse clinician has made herself very available to those foster parents to help them be the best foster parents they can. Another thing that has happened with PCIC is we've also always offered appointments to both the biological family as well as the foster parents or any kinship caregivers. So sometimes our offices can be jam-packed with folk. But an interesting offshoot of it is that the doctor tends to be, or his office tends to be a little bit of a buffer. And that kind of conversation can happen where the foster parent doesn't look like the bad guy. They're here to be the helper, while mom and dad are sorting out what their own world and their own lives. So that's turned out to be a wonderful offshoot of our project to allow everybody to be present in the room. Sometimes over the years they want to fight a little, but that doesn't happen very often. And I know I'm not really answering your question because finding expert foster parents and keeping a close eye on that is just a really big challenge. I don't think there's an easy answer.
Thank you.
Roxanne, I'd like to ask a question, please. So you obviously PCIC fills a really important niche for that group of children who have been formally apprehended and placed into foster care. And as you know better than me, there's an ongoing effort to try to reduce the number of children who are actually apprehended and placed into foster care and focus more on kinship care and staying within some kind of family setting. How do you see a program like this, or how do you see being able to sort of address that gap of the child who is not in a settled home situation but not formally in foster care, where there's many of the same issues that you face with the kids who are formally in foster care?
No, that's a fabulous question. In fact, it's a little bit like an iceberg. I mean, we started off with apprehended children, the most vulnerable population, and now we're starting to expand our program so that we're starting to see children that, for example, who'd been apprehended before, but now they're adolescents, so they're 10 years into the system. Although those kids are super chewy, big stories, they come with their own set of issues. We've also started to expand the program to look at kids that are under, say, supervision orders or custody orders where the family is still very much involved or still may even be the guardians. It's come down to, unfortunately, some practice points. They haven't been as easy to engage, and we have to sit down and sort of reflect on that, why that is. And I'm not sure if it's families that are maybe a little bit more secretive, or they don't, even though they're mandated to come to the appointments, that's where our no-show rate comes from, because generally we have absolutely no no-shows. Everybody shows up for these appointments because our social services group has basically said this is as important as court. You'd never miss court, and you're not going to miss the doctor's appointments. That's been great. I think another challenge, though, is just we need more bodies. I mean, even though right now I have 18 pediatricians, and we're trying to recruit more, I think once we have more bodies, more social workers, more dental care workers, more psychoed assessments through the university, I think we can build this program and make it bigger if we need to.
Great, thank you.
All right, we did have a question come in from the audience here, part comment, part question. He says this person is lucky to be able to, says he's lucky to be able to work in a health clinic that is physically and operationally integrated into a child welfare agency. So there's no doubt in his mind that this is the ideal model and should be advocated for. He says the care of foster children is complex and multidimensional, and it would be reasonable for academic pediatric programs to include this in the training. And we have heard a few times at these presentations bringing the concept of how much of this should be embedded into the curricula for pediatricians training or the training of other healthcare professionals. So do you have a comment for that?
Yeah, I have two actually. The first one is I totally agree that this should be a part of training. In fact, in Calgary, we've got now a rotation, what we call social peds rotation. So I believe it's our third and our fourth year peds residents now, all mandatory rotations through social peds. And it includes access to the PCIC system, visits on a First Nations reserve, visits with our child abuse clinic. So for 1 month, they now rotate, all of them rotate through a social peds rotation. So that's kind of cool. And I know they do this at a number of sites across Canada, and I think that absolutely must happen. The other one is though I challenge you a little bit. I think doing healthcare in a child welfare office can be helpful, but it also makes child welfare the focus. And I think what made PCIC successful in Calgary was, I mean, 18 pediatricians being able to do 2 assessments per month has built capacity dramatically. So it's still, there could be, in fact, in Edmonton, there is a site that is on, sort of a PCIC assessment center that is on site in the social services building, but it doesn't have to be that way. And I think if we can think outside of the box, being able to fan it out to communities, but build the resources within that can work quite well as well.
I think we're just about out of time. I think Dr. Daneman had some closing, some comments he wanted to close off with. So perhaps this might be a good time to wrap this session up with some final words from Dr. Daneman.
A couple of things. This was the second of the 2 webinars for 2015, and the 5th of the webinars we've had on social pediatrics. And I have to say, this has been fantastic. I want to thank Lisa, Lindy, Sloan, and Roxanne. They're all guardian angels of the children of Canada and the world. What a marvelous job you did today. I hope the audience agreed with that. If you look at the program for the last 2 weeks, it's brazenly physician-centric, if you will, except for Leanne Chapman, who's pro bono law office in Toronto. Everyone else is part of the CPS/Paediatric Chairs of Canada extended family, if you will, and I think that in the future we need to bring in all the other people who play a major role in child health as well and get their perspectives. But I think this has been absolutely fantastic. If we're raising the temperature on governments anywhere and everywhere, that's great. If we're raising awareness among healthcare professionals, that's great. If we're making lives better for children anywhere in Canada or elsewhere, that's fantastic. So I said fantastic a few too many times, but thank you very much, everybody, and have a good rest of the day. And thank you very much to CAPHC and Doug Maynard for keeping us in line.
Well, it's my pleasure. It wasn't easy, but it's certainly fun.
It is always great. And Denis and Jim, thank you, as well as to all of our speakers for facilitating and leading today's fantastic discussions.
Yeah, I would certainly like to echo that thanks, and I'm sure we will be back at some point in the future with our colleagues from the Pediatric Chairs to once again talk about these issues. They do bring some great content to this audience, and it certainly is appreciated from the comments that we receive from the audience. So thanks to the panel and to the audience for joining us. We do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great when you can watch live, as these questions and comments really enrich the discussion. But if you can't watch live, as I mentioned at the beginning, we do record these sessions and make them available on the Ken. We have a great lineup, but we do have a break for the next 2 weeks. They're finally letting me take a bit of a vacation, so there's no webinars for the next 2 weeks, but then we're coming back following that with our colleagues from McGill University, who will be presenting some research on the current state of policies that support leisure and fitness activities for children with disabilities, and they'll also introduce us to a new network called LeisureNet that is focused on promoting healthy lifestyles and well-being of children and youth with chronic lifelong disabilities. So be sure to sign up for that one if that's of interest to you, and you can always find more information on our website at caphc.org. At the CAPHC Presents section, you can sign up for the email notifications and reminders and all of that stuff. So thanks again for joining us, and we hope to see you back in a few weeks. Bye, everyone.